screen,
Yes,
that
madam. Yes, your
slideshow and
slides
all?
are there on the screen only.
Yeah, so everything is okay for you, no?
Yes,
Okay.
madam. Yes. Okay. Good afternoon, all the delegates. I'm extremely sorry because of some technical issues. We are commencing this session 20 minutes later than the scheduled time. I welcome Chairperson of the session, Dr. Praveen Shende, and eminent speaker, Dr. Alka Ahuja, in session 3 of 3 days international conference on pharmaceutical research and innovations to tackle future healthcare arena, organized by Gokul Education Society through Dr. M.S. Gosavi College of Pharmaceutical Education and Research. It's matter of pleasure to introduce the chairperson of today's session, Dr. Praveen Shende, working as professor in pharmaceutics at SVKM's Shobhaben Pratapbhai Patel School of Pharmacy and Technology Management, NMIMS, Mumbai. Dr. Praveen did his graduation from IPER Wardha in 2001. He is Masters in Pharmaceutics in 2005 from Dibrugarh University, Assam. He is first PhD student of Pharmaceutical Sciences from NMIMS, Mumbai. He completed his PhD in 2009 under the able supervision of Dr. R.S. Gaud. Dr. Praveen has more than 16 years of teaching and research experience with 3 postdoctorates at University of Turin, Italy. He guided 50 postgraduate students successfully, and 7 candidates are registered under him for PhD dissertation, out of which 1 student recently completed PhD. As far as research area is concerned, Dr. Praveen is expertise in novel biosensors, liposomes, transdermal drug delivery system, dendrimers, nanosponges, nanobubbles, and nanoflowers. Dr. Praveen published 130 plus research papers in reputed journals. If you look after cumulative impact factor of Dr. Praveen, his cumulative impact factor is 1000 plus. Dr. Praveen published his papers in most reputed journals in the field of pharmaceutical sciences and science. It includes but not limited to Journal of Controlled Release with impact factor 9.77, Trends in Analytical Chemistry, impact factor 12.30, International Journal of Pharmaceutics, impact factor 5 plus 1, 5.11, International Journal of Biological Macromolecules with impact factor 6.95, and Journal of Drug Targeting with impact factor 6.10. There are multiple papers in the journals published by Dr. Praveen. Total patent applications, 3 patents granted by Indian Patent Office and 1 international patent, and other 4 patents being filed by Dr. Praveen. For this session, Dr. Praveen is chairperson. I welcome Dr. Praveen on behalf of my college and organizing team. Welcome, sir.
Thank you, Prashant.
Dear delegates, we have Dr. Alka Ahuja as an eminent speaker for this session. Dr. Alka is working as Professor of Pharmaceutics and Chair of Pharmacy Program at College of Pharmacy, National University of Science and Technology, Muscat, Oman. She is chair member for more than 35 years of various academics and research committees. She, her research work presentations are presented at various international conferences held in India and abroad. 35 years of various academics. Her research work include citations in famous book of Bioadhesive Drug Delivery System, Fundamentals, Novel Approaches and Development, edited by Edith Mathovich, Marshall Decker Series, New York, USA. Besides, in high impact journal publications, she worked on major projects funded by ICMR, UGC, AICT, and TRC Oman. Dr. Alka madam has more than 36 years experience in teaching and research. She has 250 plus papers on her credit. Her papers were presented in seminars and conferences, and if you look after Google citations, she is having 10,000 plus citations in Google Scholar. Number of books authored by Dr. Alka Ahuja madam are 4, and book chapters are 4, and books published are 11. There are so many awards grabbed by Dr. Alka Ahuja madam. I am going to mention some awards out of all these awards. She got University Gold Medal Award, recipient of Indian Drug Manufacturer Association GP Nair Award. She awarded with Career and Award for Young Teachers by AICT, Asian Education Leadership Award Best Professor in Pharmaceutics, Global Education Leadership Award Excellence in Education, Leadership and Teaching. She owns several awards for best research presentations and publications, including first prize for best scientific poster presentation at Silver Jubilee. She got award in 54th and 58th IPC. She got first award for best scientific presentation at Muscat Pharmaceutical Conference, Kola Hospital Symposium, etc. She received Professor M.L. Khurana Memorial Prize for Best Paper in the field of pharmaceutics and biopharmaceutics published by IJPS. On behalf of my college and organizing team, I welcome Dr. Alka Ahuja madam. Today, Dr. Alka Ahuja madam will talk on application of pharmacodynamic principles in handling medications in pediatric and geriatric population. I welcome Chairperson of the session, Dr. Praveen Shende, and Dr. Alka Ahuja madam as an eminent speaker for this session. Madam, the session is over to you, please.
Thank you, Dr. Prashant. Actually, there is so much of background recording going on, so it will be very difficult for me to speak. Can you please make sure that it is stopped?
Just a minute, just a minute.
Because I can't. Can you please?
Madam, I removed all constraints. Please, you continue.
Because there is some background noise which is going on. There's some recording which is happening continuously.
Yes, madam. Madam, I removed all constraints. Please start with your session, please. Yes.
Okay, that's okay. I can. It's still. It's on. You know. So first of all, a very good morning, and it's good afternoon in India. And I would first like to thank the organizers of this international conference, and especially Dr. Amrutkar, the principal and the director, and Dr. Prashant from the Gokhale Education Society. And I would first like to greet you from the country where I am presently staying. This is the beautiful country of Oman. And now my topic of today's presentation is application of pharmacokinetic principles in handling medication in pediatric and geriatric population. Now, I'm sure that all of you have been hearing a lot from our great scientists, and they have been talking about the quality design, and they have been talking about the different formulation designs and formulation strategies, and they've been talking about the liposomal technology, the nanotechnology. And I would first like to actually thank my seniors, like Dr. Bhoop was my senior because I'm alumni of University Institute of Pharmaceutical Sciences, and where I did my initial education. And then my own colleagues in Jamia Hamdard, they were also the presenters here. So it's really a great opportunity to share the platform with my seniors as well as with my colleagues, and also who were my students at one time. So now I would like to pick up a topic which is very, very basic. Why? Because we talk about the technology formulation, but we should understand the principles which are involved in designing the medication. Now, let me touch upon the pediatric and geriatric population in my talk, because this is a special population. And special population means that they are different from the adults, and therefore we really need to make modifications when we are doing research for in a pharmaceutical field. Now, Dr. Prashant, I can still hear so much of the recording. I don't know what it is that. I hope the audience are not hearing that recording. Okay. Yeah, you're
Madam,
talking about
audience,
somebody receiving Mahatma Gandhi Peace Award. They are talking about that.
Madam, as such on
International Achievers Award.
YouTube, there
I
are no
don't know.
constraints, madam. Please, you
Can you
continue.
can you please can you please make sure that that is stopped? How will I make a presentation, please?
Uh, yes, madam. Yes, madam.
Somebody is thanking all the delegates now. Dr.
There.
PG Shrotriya, they are talking that. Um,
Yes,
can you,
Prashant, there is
Dr.
a
Prashant, can you please stop that, because I can't speak, because I can continuously hear that recording, please.
yes,
problem
I am
होते
also hearing the same.
I Dr. Praveen, are you also hearing the same thing?
Yeah, yes.
Yeah, so it's not possible because I have to speak, so I cannot speak with, because I am continuously getting that.
Okay, now there is no background sound.
No,
You
it
can
is.
proceed.
It's still talking about the education site, It's not possible because I have to speak, so I cannot speak with, because I am continuously.
Madam, Alka, madam,
Yeah.
as
There
such,
is
there is
echo, I
no
think.
problem at this end, and I'm listening. Yes, yes, yes. I'm listening. Yes,
Still talking about
madam. I'm listening your session. I'm listening your session on YouTube also. There is no disturbances at all. You
Okay,
continue.
perfectly fine. If there is no disturbance for you, then it is fine. I'll continue. Okay, now I'll start with my presentation. I'm sorry because of the technical thing. I had to stop in between. Now, I'll just start with
Please
this
continue, madam.
small slide, which all of you can see that this is the vicious cycle which leads to misuse of drugs in pediatric and the geriatric population. Now, you can see that the child is shooting and is telling that, oh, the doctor is saying I prescribe so many medicines because my patients expect them. Now, if you go to any doctor, normally the parents, they are so hyper until the time the doctor actually prescribes the medicine for their child, they feel that the doctor is not good. So similarly, what happens, people say, okay, I take so many medicines because my doctor prescribes them. So now this is the vicious cycle which we all need to understand as a pharmaceutical scientist, because we are involved in designing and in formulation and also in the dispensing of medication. And with my experience in formulation drug delivery for almost like more than 36 years. Now, from last few years, after I've been in Oman, I saw a different perspective of pharmacy, because the clinical pharmacy, which is the most preferred or the most working area in the United States and UK and most of the advanced nations, they work for the pharmacy and they consider pharmacy as the clinical pharmacy. So the experience which I got, and I thought I must share the different perspective from what I had been involved with. Now, I would be giving you a brief overview of the pharmacokinetic changes which happen in the pediatric population. Now, we all know that we have to give medication to the people, but now for the pediatric and elderly patients, we cannot give the same type of medication which we are giving to the adults, because they actually have a different pharmacokinetic profile. And when we are doing research, we should understand that while designing our formulations, we must consider their pharmacokinetic changes which are happening in this population. So, what is dosage regimen? Now, I'm sure all of you know that dosage regimen is designing the right dose and then also designing the right dosage form, and then the route of administration has to be decided, and at the same time you also have to make sure that the frequency has to be proper. How will you label your drug if you have not done your pharmacokinetic analysis for the formulation? First of all, you cannot bring in the market because FDA requires the pharmacokinetic studies on any design formulation. And then you also have to label whether you have to take drug once a day or twice a day or it's OD. So that is the brief introduction of my presentation today. Now, we all know that this is one class, when we were talking about the pediatric or the geriatric population, they are at the highest risk of drug related problems. So, therefore, we need to have a good understanding of the pharmacokinetics and the pharmacodynamics. Now, when I talk about the pharmacokinetics, I must know that what is pharmacokinetics. If I've designed a formulation in my research, then I have to make sure that my drug or the dose which I've administered and it reaches the plasma concentration. And plasma concentration means what? In the right effective concentration so that the patient achieves the right action. Now, at the site of action, because now whichever site you want the drug to be there, you have to make sure that your drug is reaching at that site of action, and then it combines with the receptors and the effector scene. So this is the very, very important part in designing any formulation in our research. So now, I'm sure all of you know that these are four components which we really need to understand when we are designing a formulation. We have to make sure that our drug is absorbed well. Then our drug, after it is being absorbed, it is also distributed well, and then it is also metabolized, and then also it is excreted from the body. So now, if a drug is not getting released from a formulation, it can happen that a formulation is not well designed and there is some complex which has happened and the drug is not getting released. So what will happen if our drug is not getting released? Then what will happen? Then our drug will not be absorbed also because it will not reach the blood circulation. So these are certain important points which we really need to understand when we are doing our research. Now, pharmacokinetics is basically quantification of the processes. It's not only one process, but it includes absorption, distribution, metabolism, and elimination. All the processes, they need to be properly quantified. Now, why is this research so important? Now, the reason for this is that if we are not designing our formulation well, then what will happen? If we don't have a proper knowledge of pharmacokinetics, then our toxic drugs, the drugs will accumulate if we are putting higher dose, or it can happen that our drugs, the formulation has too small a dose and it is not giving the effectiveness. Or what can happen, our drug is designed in such a way that it is rapidly metabolizing. So in all these cases, if it's very important that when we are designing a formulation, we have to make sure that we take care of all these things so that our formulation is the best formulation which can provide us the effective concentration and also at the same time not cause toxicity. Now, let's talk about the bioavailability. Now, if I'm talking about the good formulation, it means that the drug has to reach the blood circulation. What is bioavailability? Many a times, what people feel that, okay, I have taken the drug in the right dose, but I'm not getting the right response. That means there is something wrong. The drug is not reaching the blood circulation. That is definite. So why it is not reaching the blood circulation? Maybe there's a formulation problem. That is, we have not designed a formulation well, or maybe our patients, they are not complying to our medication regimen which we have designed. So we have to understand, we have to have the bioavailability studies to understand that our formulation, it achieves the right effect and the right clinical response, and also the right concentration, which is not toxic. Now, remember something, because normally people think, oh, drug has very good bioavailability. Now, drug has reached the blood circulation. It has to be effective. No, bioavailability does not talk about the effectiveness of our formulation. It only talks about that the drug is reaching the blood circulation. And whether drug is effective or it is toxic, that is a separate thing. That will depend upon the clinical or the therapeutic response. Now, if I talk about the drug formulation not being designed well, or if it is designed very well, even after that, the drug might not reach the blood circulation properly. So it might be destroyed in our gut, or there might be incomplete absorption, or it could have been destroyed in the liver. So we have to make sure that when we are designing our formulation, when we are doing our pharmacokinetic studies, we have to see that the right concentration, effective concentration, is also reaching the blood. Now, another thing which is very important in designing our formulation is, in our research, we have to check the half-life. Now, those who attended Dr. Sanjula's session yesterday, Professor Sanjula, she talked about the combination therapy. So now, when we talk about the combination therapy, now, as she mentioned, that we have to first see whether it is really clinically effective or not. I would like to add one point here also. Now, when you are designing a formulation, you also have to see half-life. Now, half-life is, it will help you to decide whether you really need to prepare a formulation. Many a times people, the drugs have very long half-life, and people start preparing the formulation which is a sustained formulation. How is that going to help? So if you go back to the lecture of the yesterday, it was so beautifully explained that how for clinical effectiveness that we have to consider so many factors. So consider, if you're designing a formulation, whether you really need that formulation or not. So check what is the half-life. If the drug has a short half-life, now you need to, that means it will not stay in our body for a very long time, and it will be eliminated fast. So now, therefore, you have to design a formulation in which you have to increase the half-life, because you want the duration of the action to be prolonged. So depending upon our need, we have to decide what type of formulation we have to achieve. Now, if I'm talking about the steady state, we must understand that when the drug will achieve the steady state. Steady state is now the plateau. You want to reach that concentration which remains for a long time, because it has to show its action. So we need about 4 to 5 half-lives. We have to calculate, and to make sure that the drug is now, only then it will be reaching the steady state. So it takes about 4 to 5 half-lives and to reach the steady state. So these are few factors which you must consider while designing your formulation when you are doing any research. Now, you have a good amount of drug in the blood, but it is not attaching to the receptors. It is of no use. So ultimately, as I mentioned, the ultimate thing comes when the drug is clinically effective. Now, let me talk about this special population. Now, we know that almost 20 to 25% population worldwide is a pediatric population, and the British Pediatric Association, it has classified the pediatric population as neonates, as infants, as children, as an adolescents, depending upon the age group. So I'm sure all of you know that when the child is born till 1 month, we have a different pharmacokinetic of that child, and so we have to be very careful with what doses we are giving, compared to when the child is 1 month to 2 years, and then from 2 to 12 years, and then when the child is from 12 to 18 years, because there are very, very marked pharmacokinetic changes which happen in these age groups. Now, if you go back to the history, now I'm sure that why these pharmacokinetic studies in pediatric population and geriatric population became very important. I'm sure all of you remember thalidomide disaster in 1957, when there was malformation of the fetus, And when thalidomide was when the drugs were taken by the pregnant females, and then the chloramphenicol, that's a gray baby syndrome it caused. It was the first time it was diagnosed in 1959. Why? Because there are certain enzymes which are not present in the children, so we cannot afford to give these drugs. So that is why the pediatric formulations, they are very, very important for us to understand how to design them, how to see that what type of enzymes are present in the children. Can we give those drugs which are giving to the adults also to the children? Now, going back to the modern era of the pharmaceutical regulations with Kefauver-Harris Drug Amendment of 1962, now it's very important that we must have FDA approval and USA marketing approval. And for that, we need to measure the efficacy and the safety of the drugs. Now, normally, I'm sure many of you know about it. We have different formula which are used to calculate the doses for the children. And we have Young's formula, Clark's formula, and we need to calculate our doses based on that. And remember, animal studies are not always predictive. So we have to carry out the studies in the children before we start actually giving it to the wider population. Unfortunately, children are therapeutic orphans because FDA does not allow many studies to be done on the children. So only you just try to reduce the dose, and that's why many problems they have happened. Now, only 20 to 30% of our approved drugs, they have pediatric labeling. Now, this, if you look at this data, now we must understand how this study is so important. Now, we do not have any financial incentives if we carry on studies on our off-patent drugs for children. And there is obviously, with lots and lots of research studies in pediatric population, now we have new labeling for 40 more drugs also. So that's gradually, it is increasing. Every year you'll find that more and more drugs, they have been added to the pediatric class because more and more research is being going on. So this is an area which is really open to research, and I would really like a young scientist to explore the area of the pediatric and the geriatric population. Now you can see in the children, there are changes in metabolic capacity. There are changes in distribution sites. They are all development changes. Their gastrointestinal functions are very different. Their integumentary development is very different. The renal function is very different. So, therefore, we have to make sure that in designing our formulation, we have to be very careful. Even for the children, you can see that they will reach the adult pH values only when they become 3 months old. Now, you know that there are certain drugs which are destroyed in the stomach, like penicillin. Now, penicillin till today, we don't have any oral formulation. Why? Because we know penicillin is destroyed in stomach of the acid, and then even if we try to make enteric coating, the drug has incomplete absorption in the intestines, in the small intestine. So we cannot have a formulation of penicillin because either it will be destroyed in the stomach, even if we try to protect it, it will not be absorbed beyond the duodenum. So that's why till date we have only injections available for that. Now, we have to consider the case even like same way for the pediatric population. Now, just look at the digestive enzymes, which are very low. The pancreatic enzymes are low in newborns. So you cannot give the drugs which require pancreatic enzymes for their metabolism. Now, let's talk about the gastric emptying also. Now, the gastric emptying is delayed, and compared to adult values, it reaches only in 6 months, they achieve those values. The motility is very slow in newborns, but only with time it increases. So we cannot give the same dose because we have to consider that their absorptive surface area is different, but absorptive surface area is much higher in infants compared to adults. So if we are talking about some application, then obviously it is different for the children. Now they have a very thin percutaneous this membrane, so their thickness of stratum corneum is actually very, very thin. So the drugs which are more soluble, which are more hydrophilic, they have a better action, they can easily penetrate through the membranes. So if you can see just the example, like topical effect is increased for hyoscine hydrobromide when it comes to absorption of the drugs. So one is the topical application. Then when we talk about even the absorption, you can see that in children there is prolonged gastric emptying, first pass is decreased, intramuscular absorption is faster. So all these parameters, you can see that they are so much different in children compared to the adults. Now, let me talk about another case like proteins. Now, we know that albumin is the protein which is present in the highest amount in our body, but in children, the protein amount is less, and even the geriatric population, the protein amount is less. But what is happening? So, the drugs which are bound to albumin and alpha 1 acid glycoprotein, which are the proteins in the maximum amount, their binding will be decreased. But again, we must know that these most of the drugs, they can enter the blood brain barrier for children. So when we are giving drugs like acetyl salicylic acid, when it is competing with certain sites, it can actually, there are certain drugs which can cross the blood brain barrier and cause mental retardation in children. So we have to be very careful in whichever formulation we are developing, and to see that it is not affecting our small children. Now, metabolism, I've already told you that liver functions, they are not so well developed. Now, just let me show you briefly about this table where we are comparing the elimination half-lives of the drugs in the neonates and the adults. Let me only take one example, like digoxin. Now, in neonates, the half-life is 60 to 70 hours, whereas in adults, it is 30 to 60. Now, you can see the half-life is much higher. That means the drug stays in the body for a much longer time compared to adults. So when we are giving digoxin to children, we have to now calculate the dose. Why? Because their elimination half-lives are because first of all, their clearance is very high. The drugs, they get cleared very high. So sometimes we have to give higher dose per kg to the infants and to the neonates and to small children compared to adults. So another like phenytoin, you can see that how this elimination half-life is changing from 0 to 2 days to almost 80 hours in neonates and 12 to 18 hours in adults. Okay, so that is how these things, they keep on changing. Now, also we must know that if the child is below 3 to 6 months, the filtration rate is lower. And now you can see that renal excretion is also changing for like digoxin, I already mentioned to you. So now let's talk about another part, that is the pharmacodynamic considerations, like warfarin. Now, warfarin is showing the relationship between anticoagulant and the patient age. So now, again, it has to be very clear whether it is a small child or it is the elderly patient. Because of its relationship with age, we have to be very careful when we are giving the drug in this form. So now, the young children, the ADRs, adverse drug reactions, they are very high. So we have to calculate the dose properly. Valproic acid, it causes hepatotoxicity. Now, these are some of the formula which I am sure you, many of you know about it. So we use these formulas to calculate the dose, the Clark's formula, the Young's formula. And now, one thing I must stress is that the children, they require much larger milligram per kilogram doses compared to adults. So we have to calculate the doses clearly. Now you can see that how the dose from 4 weeks to 2 years, then from 2 to 12 years, how the dose is changing per kg. Now we are giving lesser dose in the higher age group compared to when the child is younger. So now these are some very important examples which are very important when we design our formulations. Now, there are certain drugs which are having faster elimination, like antipyrine, clindamycin, phenobarbital, ethosuximide. So then, obviously, we have to see that how these drugs they get eliminated. Now, remember drug metabolism. Now, sometimes people feel that okay, the mother has received the drug, but how is it going to affect the child? If mother received the drug like phenobarbital, it caused early maturation of the hepatic enzymes. Then what happened? The neonate was able to metabolize the drugs greater than expected. Now you gave the drug in a certain dose and you thought that how this drug is getting metabolized because I calculate the dose properly. But you did not take into consideration that mother also received the drug and then her drug was actually leading to this induction of the enzymes. So like we can easily see that how these small factors are related. Now if you did not consider that the mother receives certain drug and you change the drug for your child, that means now you're harming your small baby. So therefore you also have to make sure that such effects can lead to less therapeutic effect, lower plasma concentrations. So we have to be very careful when we are doing all these dosage regimen designing. Now, T half, already I told you that it is increased for the children, like gentamicin and penicillin. When it is given to children, the T half is prolonged by almost 3 to 5 times. So now I think I've given you enough picture about the pediatric population, how we have to be careful in designing their dosage regimens and designing our formulations. And in the geriatric population, the most important thing which we need to consider is that now they consume a lot of OTC drugs, which we normally tend to miss out. We will only ask, the doctor will only ask what other prescription drugs you are changing. But the statistics shows that they consume almost 40% OTC drugs, what is actually leading to higher risk of adverse drug reactions. And more than 35% patients, they are using more than 6 drugs. Now this is the major problem which is seen in the elderly population. And therefore, and polypharmacy and OTC drugs, they are complicating their drug regimens. Now they have definitely altered drug response. We must understand that their pharmacokinetics is totally changed, their receptor sensitivity is changed. So as the age progresses, some special changes happen in the geriatric population. Their absorption is reduced, their motility is reduced, their emptying is reduced, and even their these non-steroidal anti-inflammatory drugs, they are taken more in the elderly population. But we know that they're also taking antacids because the acidity problem becomes more with age. But these two, they react with each other. Then the blood flow to the GIT tract is also reduced because cardiac output with age also changes. Then the medications which undergo first pass metabolism, they are absorbed more completely in the older patients. Now we can see that such changes happen, and if we do not consider these in designing our formulations, we can end up harming our geriatric population. Now, if you look at these are few examples of bioavailability and bioequivalence differences. Like the most popular examples are tolbutamide, phenytoin, prednisone, furosemide, digoxin. You'll find that bioavailability and bioequivalence differences are a lot in this population. Now, when I look at the GI disorders, I must know that if the problem of enteritis, gastrectomy, and other concomitant use of the other drugs, they can all affect the GI function. So we have to be very careful, because many of this geriatric population, they are a lot on laxatives, antacids, ion exchange resins. So we have to be very careful when we are adding another drug to them. Now, another point is about the distribution changes. Their body fat increases, lean muscle mass decreases, the albumin content again decreases in the elderly population, the cardiac output changes, the total body water also. It is not the amount of water which reduces, but in proportion to the fat, yes, the water fat ratio, when we are talking about that, yes, it is much lower. So, if we are giving those drugs which have binding with alpha 1 acid glycoprotein, we will find that alpha 1 acid glycoprotein is increased in the geriatric population. Whereas in the adults, you'll find when you're comparing this, so all the drugs which are bound to alpha 1 acid glycoprotein, you'll find increased binding. So when the binding is increased, you know that drug action is only because of the free drug which is available. Then we will have less free drug, so obviously the action will be affected. So we have to also see these factors when we are preparing a formulation for the geriatric population. Now, remember that when we are giving lipid soluble drugs to our elderly population, because they have more fat content, the drugs will be taken to a larger extent. Then their volume of distribution is also, for the drugs which are lipid soluble, that will be increased, because they will be more going to the organs and tissues. When there are more volume of distribution increases, it means that the drug has a longer duration of action. So all these things we have to consider. But again, between male and female, you have to consider, because there are different equations which are used to calculate the doses for men and for women. And also they are based on the height of the male and the female. Now, all these have to be used when you are calculating the dosage regimen for your design formulation. Now, you must know one thing, that this is just the example which shows the distribution sites, how the changes happen in the distribution sites. Now, you can see that if you look at this, um, now, total body water, it is higher, but with age it is decreasing. Extracellular water, it is higher, and it is also decreasing with age. But body fat, it is less, and it is increasing with age. So you can see how these development changes happen with age, which we all need to be careful when we are giving the drug. Now you can see the example of diazepam and antipyrine. Now, why this difference is there? The diazepam, we know that it is more lipid soluble. So now what is happening? The volume of distribution is increasing with age, because it is lipid soluble. But antipyrine being water soluble, you can see that its volume of distribution is decreasing with age. So depending upon the characteristic of your drug, whether it is water soluble or it is lipid soluble, you have to design your geriatric and pediatric population based on that. Now, when I'm talking about the metabolism of drugs, now I must know that there is decreased hepatic blood flow because of the decreased cardiac output in geriatric patients. Their hepatic mass is less, hepatic enzyme activity is less. That's why the drugs which are undergoing first pass metabolism, I mentioned that their metabolism will also be reduced. Now, we know that some hepatically metabolized medication, their elimination will be decreased. The examples, like if we are designing formulation for beta blockers, or for lidocaine, or theophylline, or narcotic analgesics, we must consider all these points. Now, all these, basically, we know that the major enzyme system in our body, cytochrome P450 enzymes, their reactions, they are slowed dramatically as a person ages. With what is happening now, so therefore the action for the phase 1 metabolic pathways, you'll have find a prolonged duration of action. But when it comes to phase 2 reactions like glucuronidation, etc., they are unaffected by aging. But when it comes to oxidation, reduction, etc., they will be affected, but these phase 2 reactions will be unaffected. So these are certain things we have to see, that our drug, it is metabolized by phase 1 reaction or by phase 2 reaction. So depending upon the metabolism pathways, we also need to design our doses. Okay, so now you can see that we have to calculate the dose based on these better pharmacokinetic changes. Now, when it comes to excretion of drugs in the elderly population, again, there is decreased renal flow, the filtration rate is also decreased, the tubular secretion is reduced, and because they have less, also decreased number of nephrons. So now, we must know that when we want to avoid drug toxicity, we must adjust the dose of the drug depending upon the creatinine clearance. Now, these are certain factors which, as a researcher, one must take into consideration. Now you can see this. Now, if you look at this antipyrine clearance, you can see that these are, metabolic clearance rate. Now, how it is decreasing and how there is so much of variation which happens with the age. Now, let's talk about the renal clearance. Now, we have to adjust the dose, whether it is the pediatric population or the geriatric population. So, which equation are we using? It is Cockcroft-Gault equation, which is used to understand and how to calculate the creatinine clearance. And if we want to calculate for the female, this formula has to be multiplied by 0.85. But otherwise, this formula is used to calculate, and it will help us to find out the creatinine clearance, and we can design our dosage according to that. Now, one thing is, we must remember that VD is very small for water soluble drugs. Yes, smaller, like small means smaller, we are comparing it with the adults. Now, clearance is also, it is diminished with age. Now, let's talk about some other physiological changes, which besides what we have discussed now. The pH of the gastric secretion is definitely increased, the peristalsis is decreased, and blood flow is decreased, cardiac output is decreased. And so we have to now understand all these when we are designing our drug formulations. I'll not go into many details about the diseases because I'm sure that we know with age, cancer is more prevalent, then stroke and hypertension and bronchitis and upper respiratory infection, the UTI. These infections, they become more with the age. So, and when we are designing formulations for this, we must consider the proper changes which are happening in the individuals. Now, another problem in the geriatric population is depression. You'll find many people with age, they get into these depressive modes, they get into dementia, anxiety, they tend to also forget even if they have taken the drugs or not. So many behavioral problems, they happen, and they're also leading to the drugs which they are taking. So we have to be very careful when we are administering analgesics, because these are all the problematic medications in the elderly population, whether it is analgesics or it is non-steroidal anti-inflammatory drugs, or we talk about anticoagulants or antihypertensives or digoxin or hypnotics or thyroid diuretics. All these, they have a major impact when we are designing the formulation. Now, let me just talk about this formulation. We all know that insulin and gentamicin, we have to give them as injections, because these drugs, they are again destroyed in the body. We cannot give them as in the oral form, although scientists are working a lot in preparing oral drug delivery system. Hopefully, we will see the light one day, but still you will find that very high concentrations are needed, and still they are not achieved by the oral administration, especially in the cases of meningitis, osteomyelitis. And so therefore we have to consider that which we have to do the pharmacokinetic analysis of all the drugs which we are preparing for research. Suppose you have designed your formulation, and the moment you did your pharmacokinetic studies, you realize that drug was destroyed in the acid. That's why we do all in vitro testing before. We check in different, we do dissolution studies, we check in different media, so that to make sure that our drug is released from the formulation, it is stable in the media. We try to mimic the in vitro, in vivo conditions, so that our drugs, so that we have a clear understanding when we administer the drug in the body. So therefore, we have to do all these studies systematically when we are designing a formulation. Before jumping to in vivo studies, we should do detailed in vitro studies to understand that how drug is getting released, how it is getting absorbed, how it is getting, what is the stability of our drug in the particular medium. Like you will find a lot of, like yesterday Dr. Sanjula was talking about so many irrational combinations. Now instead, I will talk only about the irrational, even single formulations. I'm not even talking about the combinations, even the single formulation like paracetamol injections. These drugs, they are very well absorbed, so why do we need to give injections? And sometimes people feel that, oh, I have taken an injection, the acts faster. Multivitamin injections, glucose and calcium injections, H2 antagonists, inhibitor or proton pump inhibitors for gastritis. All these are the irrational use of the injections, which we really need to understand when we are designing a formulation. So if you start thinking that, oh, I have to design a formulation, think about the rational, whether it's really relevant or not. Now, never dismiss the thing that our CNS effects, they change, our ANS effects, they change. People suffer from various problems like orthostatic hypotension, then pulmonary changes happen. All these changes we need to consider when we are designing our formulations. Now, how do we adjust our drug therapy? Now, there are so many websites. We have FDA, government, and professional websites. Just go to them, see what is the drug profile, how whether your research which you are going to do is justified or not, or you are just wasting your time designing a formulation which is of no clinical relevance in the future. Now, like the same, sometimes people think, okay, let me design the formulation with the same doses, etc., and just slight modifications. No, that will not work. Remember, all these changes, they will be found as the people age. So you have to be very, very careful. I'll just touch one example here. Now, if you are giving this dose to the elderly, thiopental dose. Now, thiopental, when it is given to the elderly population, remember, they have a very small central compartment. They have more of the peripheral compartment. So when they have small central compartment, so when the small concentration of the drug will lead to more sensitive reactions. So you need very low dose of the anesthetics to achieve the same effect. So you cannot give the same dose as you were giving for the adults. So you have to decide all these things, that whether what is the size of central compartment for that person, what is the size of peripheral compartment, what is the solubility of the drug, and whether this population has more of water content or they have more of fat content, and whether our drug is lipid soluble or drug is aqueous soluble. Now you can see there are certain classes of drugs which are of high risk, like digoxin, phenytoin, warfarin. We have to be very, very careful when we give these drugs. Okay. So now I will just talk about, I'll just end with some examples where we are totally irrational, like combinations, norfloxacin, metronidazole, norfloxacin, tinidazole. You'll find lots in the market. But now, as Dr. Sanjula was mentioning, that yes, now the committees are being set up and they're trying to work on reducing these combinations, which are totally irrational. What is the use of combining anti-amoebic with antibacterial? Because patient suffers only one type of diarrhea. You are just unnecessarily increasing the cost. So we have to be very careful when we are designing our formulations. Nimesulide with diclofenac, nimesulide with paracetamol, nimesulide with cetirizine. are these combinations of any use to us? They are only increasing the side effects. Nimoslide is banned in many countries, but you will still find combinations on the counter. And you will find we normally tend to ignore the herbal formulations. Remember, these herbal formulations also have lots of interactions, and elderly population takes all these. The research says that they take a lot of these herbal formulations because they are easily available over the counter. So they feel that, okay, let me use them for anxiety, because anxiety increases, depression increases, so they use all that. But they have been found to have lots and lots of these interactions with that. So I would just end my presentation with some take home points, that elderly, they obviously take more medications, but their pharmacokinetics and pharmacodynamics, they are altered, and adverse drug reactions are very common in pediatric and geriatric population. The risk involved with taking these drugs is very high. Non-prescription and herbal therapies are very commonly taken. So we have to be very careful when we are giving these formulations, when we are designing our drug formulations. So in the last few years, I had the opportunity to work here with some hospitals, and I could do some studies on the pediatric and geriatric population, because here the hospitals, they are very active in the clinical research. So I got the opportunity to work with some clinical pharmacists, and I found that this was a new area which I had never explored. So I was always into drug formulation delivery, designing the floating drug delivery systems, nanoparticles, or the nano formulations, nano emulsions. I always used to think biodiesel drug delivery systems. I never thought that clinical research could be so interesting. So I have like a few publications in this area in last few years. So these are some of the publications which I could publish in some good index journals and some impact journals. So I felt that I must share this interesting area of research, which our young researchers can always explore. And even if you have to do some studies with the hospitals and how they are giving these drugs to small children and to the elderly population, I think it will be a very interesting area to explore. So remember that this is something which we all must study. So I will just thank you for your patient listening. And India being my home country, that's where I belong to, and this is the country where I work, and which has given me also enough opportunities to learn new aspects of pharmaceutical research. So I thank all of you. And obviously I thank my country India, where I received my education and I got the opportunity to work, and also I learned a lot in Oman. So thank you so much, everyone. And if you have any questions, I'll be very happy to answer. And I'm sorry if I took more time, but I just wanted to share a few points. Dr. Prashant, if you feel fine, then I can stop sharing. Or
Yes, madam. Thank you, madam. Thank you.
yeah, can I stop
Yes,
sharing my slides?
yes, madam. Yes, madam.
Okay,
Please.
thank you. Yeah.
Thank you, Dr. Alka, madam, for your fantastic session on application of pharmacokinetic principles in handling medication in pediatric and geriatric population. I sincerely request Dr. Praveen Shende to conclude this session. If there are some questions, I will just put the questions. Just a minute.
I would really like to thank Dr. Praveen Shende for chairing the session. I'm sure with his expert and his wide experience and expert opinion, the audience will definitely benefit.
Thank you, ma'am. I have two questions, okay, before coming to the audience, okay.
Yes, sir. Yes, sir. Please,
First,
sir. Please.
yes, first, how will you correlate pediatric and geriatric dosage regimens with the adults?
How will I correlate?
Correlate. Yes.
Correlate, as I mentioned, that definitely we cannot give the same doses because their pharmacokinetics and pharmacodynamics is totally different compared to the adults. So therefore, we have to calculate the dose based on different formula, and also we have to do these studies. There is no shortcut to that. So we have to do these studies in the pediatric population to be very sure of that. So now, even if you look at FDA thing, as I mentioned, that only 20 to 30% drugs which are used in the adults, they have been extrapolated to pediatric population. So we need to do more and more studies. Only
Okay.
that we can correlate.
And second question, that means you know that the animal models are mostly for the means adult dose. Okay. Are there any animal models available for the pediatric and the geriatric patients?
If you look at where I also mentioned that animal models are not the predictive, they are not of, definitely they cannot predict. There is no choice. So only thing is that we have to monitor the concentration, and we have to see the effective concentration and the clinical response. So animal studies are only to find out the toxicity profile. So definitely not that. So that's why we have to give the proper consideration to the labeling. And for the dosage regimens for pediatrics, we have to have special labeling requirements.
Yes, and I think this area will explore mostly in the personalized medicine in the future.
I totally agree with you because I never thought of this area till the time when I saw in Oman that how the doctors and the pharmacists and the clinical pharmacists, they're working so closely, and they're doing lots of studies in the outpatients, in the inpatient pediatric and geriatric population. So they are giving different formulations, and they are checking them, they're monitoring them, and that is how they're able to find out very interesting studies. Even the reconciliation or even the use of alternative and complementary medicines in pediatric population, I had never thought that this was another area. And like what we consider ginger as like the normal or like part of our food, but they consider as the complementary and alternative thing. So if they are giving even that, they will count it like that. Even honey, which are normally food items for us. So there is a different research which is happening for children, no? So, so
Okay, any
I'm
question from the audience? Okay, thank you,
okay.
Dr.
Thank you so
Paula
much.
ma'am,
Thank you.
for your
Thank you.
contribution toward the success of this conference and inspiring everyone. Today, we had an opportunity to hear your thought process for the pediatric and geriatric population research, and it is challenging aspect when we consider about the dosage form and volume of distribution, and this is surely be going to encourage us for more research toward the development of new technologies in pharmaceutical uh, industry in the future event. Now, if I want to correlate this area, I will correlate this with the COVID-19 vaccine. And as you are aware that the still we are struggling for the vaccine for the pediatric. Okay. So, ma'am, your deliberation and research in this area will definitely help our researchers who are working in this new field. And moreover, thank you, Principal Sir, Dr. Prashant Pingle, and all the organizing committee members for inviting me as a chairperson in your conference.
Uh,
Thank
Dr.
you.
Praveen, if you give me a minute, I would like to share my experience with the pediatric vaccination here, because
Okay.
Oman, Oman, they already vaccinated children from 12 years above. A mass
Ma'am, which
population, the
vaccine?
schools, COVID-19, they have
No, no,
given
which
Pfizer
vaccine, which
vaccine.
company, which brand?
Pfizer, they have given Pfizer to children all above 12. They've opened the schools, they've opened the universities now, and all the children in the schools, they have been vaccinated. And they made compulsory, they made it mandatory that children have to be vaccinated, and people have shown extremely positive response. And the way they have given the children vaccine, it was amazing, you know. So I can see that there is a different perspective in different countries, and India
Yes.
has still not opened vaccination to children 12 years and above, but Oman has already completed the vaccination for the children in this age group, you know. So,
That's great, ma'am.
yeah. Okay.
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 Thank you,
Thank
madam.
you.
Thank
Thank
you.
you so
Thank
Thank
much.
you.
you. Thank you,
Thank
Thank
Alka
you.
you.
madam, Praveen sir. I would
Thank you.
like to say thanks to Dr. Alka madam. Madam, by listening to your talk, application of pharmacokinetic principles in handling medication for pediatric and geriatric population, I remember a quote of Albert Saint Kairogi. I think he is famous biochemist from Hungary, Hungarian biochemist who won Nobel Prize in 1937 in physiology and medicine. He says research is to see what everybody else has seen and to think what nobody else has thought. So by looking after your presentation, by listening after your presentation, it is truth thought by Albert Saint Kairogi. On behalf of my college, I am thankful to Dr. Praveen Shende, Professor SPP SPTM NMIMS Mumbai for chairing a session. Thank you, Dr. Praveen sir.
Thank you, Prashant.
The session will not be complete unless and until I will say thanks to Dr. Alka madam because of her busy schedule. In spite of her busy schedule, she gave about 1.5 hours to deliver a talk on such a wonderful topic. I must say thanks to Dr. Alka madam. Thank you, madam. Thank you very much.
Thank you. Thank you so much. Thank you so much.
Thank
Thank you very much. Delegates, dear delegates, tomorrow is the last day of conference, day 3, Wednesday 29th of September 2021. We will have 3 sessions. There is some technical problem associated with session 1. Those who are interested in microbiology and nanomaterial and future drug correlation of these with endophytic fungi in synthesis of nanomaterial and future drug is the topic of talk by Dr. Afsar Ahmad, who is director at Interdisciplinary Nanomedicine Center at Aligarh Muslim University. Those who are interested to join this session, Google Meet link will be shared on Telegram group as well as on your WhatsApp group. You will be joining this session. This will be wonderful session by Dr. Afsar. The second session will be at 11:10 to 12:10 Indian Standard Time. Dendrimer technology for next generation siRNA delivery modality by Dr. Rakesh Tekade, Associate Professor, NIPER, Ahmedabad. And the third session, last session of this conference by Dr. Anand Bhandari. He will be talking on product lifecycle management in pharmaceutical industry. The session will be continued till 13:20 hours and the valedictory function will be immediately after the third session at 1:30 p.m. of Indian Standard Time. It will be completed by 2 p.m. of Indian Standard Time. Thank you very much. Thank you all the delegates. With the kind permission of Chair, Dr. Praveen Shende and keynote speaker, Dr. Alka Madam, I would like to end the broadcast of this session. Can I please?
Thank you. Thank
Yes.
you once again.
Thank you
Thank
very
you.
Thank
much.
you.
Thank you.
Have a
Thank you.
nice day.
Thank you.
Thank
Have a
you.
Thank
nice
you.
day.
Bye.
Thank you.
Bye.
Thank you, madam.
Good day.